Today, we delve into a compelling medical mystery, a case of resistant hypertension that challenged our diagnostic skills. Our patient, a 55-year-old man, presented with resistant hypertension, persisting despite a 3-drug regimen including HCTZ, amlodipine, and losartan. His blood pressure remained elevated at 152/98 mmHg, yet surprisingly, his potassium levels were normal and he reported no other symptoms. This presented a significant puzzle: persistent hypertension despite what appeared to be adequate therapeutic intervention. To unravel this, we considered a broad differential diagnosis for resistant hypertension. First, we evaluated common factors like poor adherence to medication or the white coat effect. Next, we considered renal parenchymal disease and renovascular hypertension, both significant contributors to elevated blood pressure. Obstructive sleep apnea was also on our list, a frequently overlooked cause of resistant hypertension. Finally, we explored endocrine causes, including pheochromocytoma, Cushing's syndrome, and thyroid dysfunction. Among these, primary aldosteronism stood out as a potential candidate. The key clue in this case was the normal potassium level, which might seem counterintuitive. However, up to 40% of primary aldosteronism cases present with normal potassium, especially in resistant hypertension. The persistent hypertension while on ARB therapy, specifically losartan, was another critical indicator. Therefore, the absence of hypokalemia does not rule out aldosteronism. Our diagnostic reasoning then focused on the expected physiological response to losartan. Losartan and ARB should typically raise plasma renin activity, or PRA. If PRA remains suppressed despite ARB therapy, it strongly suggests that aldosterone secretion is autonomous. The next best step was clear: measure plasma renin activity. If PRA was suppressed, we would then measure plasma aldosterone concentration, or PAC, and calculate the PAC/PRA ratio. We systematically ruled out other diagnostic approaches. An adrenal CT scan at this stage would be premature, as biochemical confirmation is essential first. Measuring aldosterone after sodium loading is a confirmatory test, not a screening one. And a 24-hour urine potassium measurement would be irrelevant without hypokalemia. Thus, the correct next test was indeed plasma renin activity measurement. The results confirmed our suspicion. PRA was suppressed, and the PAC/PRA ratio was elevated. This led to the diagnosis of primary aldosteronism, with suspicion of either a unilateral adenoma or bilateral hyperplasia. Further investigation with the CT scan revealed a 1.5 centimeter adrenal adenoma. The patient underwent adrenalectomy, and remarkably, his blood pressure normalized on fewer medications. This case offers several teaching pearls for fellows. Resistant hypertension is a red flag for secondary causes, always prompting a thorough investigation. Remember, normokalemia is common in primary aldosteronism, so don't let it mislead you. PRA suppression on ARB or ACI therapy is highly suggestive of the condition. Always confirm biochemically before proceeding with imaging studies. And finally, some causes are surgically curable. Don't miss these opportunities for definitive treatment. The moral of this story: when hypertension resists, look beyond the numbers. Sometimes, the quietest electrolyte hides the loudest diagnosis.